and I'm Director of Policy and Strategy at NHS Providers, and I'm delighted to be chairing today's session, which is about putting Vanguard plans into practice. And we're going to run today's session slightly differently in that there's going to be a kind of Q&A interview between me and my two esteemed colleagues here, and then we're going to open it up to wider question and answer. So I beg your patience for listening to start with, and then we will bring people in. So I'm going to introduce our two interviewees to you. On my left, we've got Heather Tierney-Moore, who's Chief Executive of Lancashire Care NHS Foundation Trust. And on my right, we've got Jackie Daniel, who's Chief Executive of University Hospitals Morecambe NHS Foundation Trust. And I only read those out because often it's so easy to get a trust name wrong, and I don't want to do that. And they're more and more complicated as time goes on. So really, what we wanted to do today was to find the opportunity with two trusts that are coming together in a new Vanguard plan and proposal to really talk about what this means. What's the nuts and bolts, hands-on impact of pursuing a Vanguard under the new, 5-year forward view, 4-year forward view now, as it is, and to think about all of those elements that you really need to take into consideration when pursuing this. And I think one of the things we really want to get under the skin of is not just the hard facts, but also the soft stuff, which is the bits that we know actually make these things work. So I'm going to kick off to start with and just ask both of my colleagues just to tell us a bit about their PACS model. And for those of you who don't remember what the acronyms stand for, and I've got it written out here to remind myself, it's a primary and acute care system. So I'm going to turn to Heather first, just to talk a bit about that and perhaps your general context and how it's working.
Well, certainly, when we started thinking about this, we were quite uncomfortable with being labelled as a PACS, because that wasn't really how we saw it working through. And obviously being part of Vanguard was important to us, so we were happy to stick with the title. But the reality really is it's more like 12 MCSPs with an acute provider as a kind of overarching part of that. Because at the heart of the models that are being developed are 12 neighbourhoods based around primary care, very much a kind of place-based approach, and then considering how the acute services support and span across those, rather than starting as the acute provider being the kind of prime focus, and then how does the rest of the system work to that. I mean, my personal involvement is that I'm actually the mental health provider to about half of the locality. So for me, it's a very small part of my whole business, probably only about 4 or 5%, whereas for Jackie, it's 100% of her organisation. So we're coming at it from very different perspectives, but with the same commitment to saying, what is it that the population needs? And I'll perhaps invite Jackie to talk a bit more about the nature of the population we're seeking to serve, because there are some particular issues that we face across the Bay. But really thinking about, so what needs to be different for those different communities, because for parts of North Lancashire, the challenges are different from other parts of Cumbria.
Yeah. Jackie, do you want to contribute there?
Yeah, just to add to that, the kind of geography is relevant. Most of you will probably, on your visit through our patch up to the Lake District, will appreciate some of it. But, as a trust, we have 3 main sites across a geography and a population that would probably barely merit 1, if you're looking in kind of average and certainly tariff terms. So when I joined the organisation 3 years ago and was kind of scratching my head thinking, what do you do with a problem that was, and, to a large extent, is an improving position, but still is Morecambe Bay, where most of you will know had got pretty catastrophic quality failures, but really born out of a broken model of provision, and certainly kind of salami slicing, year-on-year cost improvements. So, yeah, population very dispersed, very different. So in Barrow in Furness, we've got some of the most, challenged wards in the country. People in Barrow, men on average are living 6 years less than the England average. In Lancaster, it's a much younger population. A lot of students with the university there, very different issues. In Kendal, people often come and retire, so lots of wealthy elderly people. But yeah, really, really challenging geography to deal with.
So, for a bit more clarity for the audience, what we've got is Morecambe Bay, and it's the totality of your services coming under the PACS, and for your trust, it's part of what you do. Could you just talk about that part, just so we can make that clear?
So I provide the mental health services to North Lancashire. My colleague from Cumbria Partnership provides the mental health and community services to South Cumbria. I then provide mental health services across the rest of Lancashire and a lot of physical health services in certain parts of Lancashire. So I'm actually involved in 2 vanguards and 3 other sub-health economy transformations. So it's interesting for me in particular to have got a kind of live, almost not quite a randomised control trial, but certainly the opportunity to compare and contrast how things are working in Morecambe Bay, how things are working in other vanguards and other areas that haven't got the label of vanguard but are trying to do very similar things. And it has quite important implications for my organisation, and we'll probably later talk about how we're supported by the centre and how people understand how things are developing in terms of regulation, etc. Because I just live in a world of Venn diagrams, and nothing is neat for me in terms of how my organisation needs to fit.
And it's probably worth just going on to say, just building on that. So there are 11 organisations in the partnership. So 4 FTs, 2 local authorities, and 2 big GP federations either side of the patch starting to get involved, 2 CCGs. But it's a really important point that you make there, because I've seen Karen Partington in the audience somewhere, but, whilst we're kind of 100% of the vanguard in the Bay, we play into the hospitals group down the Lancashire coast. So I think that Venn diagram world is probably familiar. I can see a lot of people nodding in the audience. We're all going to be living in Venn diagrams, multiple Venn diagrams, if that makes sense.
I think the watchword at the moment is ambiguity, isn't it? And
Yes.
how you start to assess the nature of your relationships and where you fit within that. Can I just ask you to expand, and I'm going to ask you first, Jackie, to expand a bit more on the kind of raw motivation for you pursuing this approach?
God, the raw motivation starts with taking on a job with the kind of quality failures that we're seeing across the patch. It starts with the patient experience and what we're offering for the population. It was broken then. These solutions weren't easy. So we've been building this model way before 5-year forward view came into sharp relief. But I think, I can say hand on heart for all partners, I'm looking at Heather, but it is absolutely to leave a legacy for the next generation of that population in the Bay.
Excellent. And what do you think the key outcomes are going to be? What do you hope they're going to be?
Well, I think, one of the reasons I was very keen to be involved right from the start was to really try and make the most of bringing physical and mental health services together, and really think differently about what is the nature of that. So it's not about saying, oh, well, we've got some established mental health services that we just want to be linked with some physical health services. It's actually about saying, what is the notion of parity of esteem? What is the notion of well-being? What are the opportunities to support individuals in a way that is truly holistic and that actually makes a difference, rather than just joining up bits of the system a bit more? And for me, that's where we're trying to come at it. So really coming at it from a population health perspective, rather than how do we just fiddle around with some health services and some care services and make them a little bit better than they are? So the opportunity to kind of tear up all of the rule books. So for instance, when we're thinking about what might be the mental health component of some of these pathways, it's probably going to involve some very different kinds of people than we currently have. It's not about me dropping a CPN or a psychiatrist into a physical health team. It's probably something very different. And how we've been working with communities. Again, it's a very different model. So there's still a long way to go. I'm not suggesting that we know what the answers are, but I think we're just asking some really big questions.
I think that's what struck me in talking to people involved in different vanguards, is actually how places are seizing the structural imperative and turning it into benefit for patients. And that's just what you've articulated there, I think, and is really, really compelling about the vanguards that are doing it well, really, in a sense. It's about how do you pull that out of what is deemed to be a structural solution. I suppose what we've got here is a situation where this is part of your endeavour. This is the totality of your endeavour. That could be, in certain hands, a quite combustible working relationship. I wonder if you could both kind of enlighten us on how you work together, because I think one of the fundamental things is about how people work together around these bringing together structures. So, Jackie, I think
Shall we tell the pretend story or the
real
real
the
one?
real one? That was the deal.
No. Okay, the deal. Yeah, absolutely. Well, we have been at it a while, so I guess that's the first thing to say. 3 years, in actual fact. Probably in earnest, 18 months in terms of the relationship building. And we do disagree. We've had some really tough decisions about, particularly, we're moving to a shadow MOU and ACS, which is going to be real. It's going to have a real budget. It's going to have a real delegated responsibility for what we're coming to know as Better Care Partners. And with that, there's territories which is difficult not to kind of guard fiercely. And as the one that does sit squarely 100% in the patch, what I have to do is remember that, the 3%, the 4% is every bit as important, if not more important, in actual fact. And I've got to learn to kind of tone it down, which those of you who know me well will know that that's not an easy task, but I try and do it.
And what about from your perspective? It's very different for you.
It is very different. And it would have been very easy for me to say, do you know what, actually, it's a tiny bit of the business. We haven't really got much of a role to play. Initially, most of the conversations were about physical health. And when you're thinking about which meetings do you prioritise, it would have been really easy to go, I won't bother with that. But I felt it was really important that we play our part, and that, being very selfish about it, it's a great learning opportunity too, to be involved right from the beginning, and to really think then about how can I take what we're learning from here to apply to the rest of Lancashire and help spread some of that. And trying to avoid being a kind of broken record about going, what about mental health? What about mental health? But actually we did a bit of that at the beginning, and then now other people are going, yeah, but what about mental health? And you're thinking, that's fantastic, I don't have to mention that anymore. And you can play across the whole agenda. I think the thing that I really like about working with the Morecambe Vanguard is the quality of the relationships, though, because we've got past the just being polite, and so some of the tension is absolutely what you need, because if we're all just in that kind of group think and nobody's challenging each other, then we're not going to make the right decisions. So we're kind of got a more of a grown-up relationship now, where yes, we disagree. Sometimes it gets a bit tense, but we're big enough to work it through.
Yeah. I think the thing you say about repeating over and over again, what about mental health? They do say that when you're sick of saying it, the message will finally have got through. So clearly, that was the case.
It probably is really important to talk about our commissioners, because they're not here. We work with two commissioning groups at the moment. They have really worked as one for the last year, 18 months, and they will come together. And we in in the ACS, there will be commissioners and providers sat side by side, either making or buying our services, and they've been fantastic, I have to say, and we're really lucky. And when I look, and talk to other providers, I don't see the same kind of quality and the same maturity in terms of leadership. So I feel really privileged that we've got that.
I would absolutely endorse that. I think the partners that it's been hardest for actually are the local authority, and particularly Lancashire County, because they've had to go through huge amounts of structural change. They've got all of the financial challenges. A lot of their solutions to just managing, because of their financial position, is to kind of adopt an approach that works for them. And this isn't a criticism, it's just recognising where they are. So their ability to be as engaged and as flexible as we might want to keep the pace going in Morecambe is a real challenge for them. And they understand that, and we share that with them. But it is a real issue. And as we move into things starting to be really different, ensuring that we've got elected members really well sighted on of this and supportive of it is going to be really important.
Yeah. I think that's certainly what we're hearing, is that the role of elected members is coming centre stage, probably in a way that they, of course, have been there in the local authority setting, but not as prominent as they are now in all of the different arrangements that we're seeing.
I mean, I think that's so vital as well. If you are taking a population health focus, we're very fortunate to have a lot of public health. My medical director, quite unusually for an acute trust, is a public health doctor, and we've got a number of public health experts in the patch. It's going to be so important that we look across housing, we look across employment, education, etc. We're beginning to do that, but clearly, we're a long way to go on that agenda.
I'm going to open it up now for Q&A, and hands are going up already. Before we ask questions, can I just have a show of hands? Who in the room is involved in some kind of Vanguard project? Okay, I see why you're here. That's really helpful to know. Isn't it the case, I think, that the first round of Vanguard should reach 10 million population, so I think it's heartening to see so many of you here. We've only got one microphone in the room, so please bear with us as our colleague gets to you. So got the microphone coming to the gentleman there in the yellow tie. Can you say who you are and where you're from?
Yes, Hugh Morgan-Williams, Chair of NTW, Mental Health and Disability Trust in the northeast of England. Vanguards are very complex beasts, and they involve multi-agency working and multi-partner working. So my question is really, how have you modified your local accountability and governance arrangements to take account of both democratic involvement, but also in terms of the governance of all your respective organisations? How are you dealing with that?
Okay, Jackie, I'll come to you
Okay,
first.
I'll start. It's difficult for me not to rewind the clock a bit. We've had what we call a programme board. We actually put funding in there for 3 consecutive years, from our own funding to, resource things like OD development, backfill some of the really key posts to do some of the design work. So that was in place, and I guess there was an implicit rather than an explicit sign up from all governing bodies and boards. We're just about to, if you look on any of our websites this month, we're taking through our memorandum of understanding for the ACS through every single governing body and board. So you'll see quite a lot of detail there about the proposed governance structure. But we kind of did what we felt was right for a couple of years, really scientific, I know. And we tried to. The other thing that we did, which was probably important, was we just didn't overkill it with project management, because we've got a lot of clinicians involved, and if there's one thing, it just turns them off completely. So we've got through all the gateway reviews, but we've tried to do it with kind of project light, if you like.
Could I just, perhaps a question that Hugh might follow up with was, if your chair was here, what would they say about the lines of accountability and how do they feel? Sorry to put you on the spot,
No,
but I think it'd be interesting
I think he would
tease
I
that
think
out.
Piers Butler, if he was here, would say it's felt quite scary at times because he's let us get on with it. We have had a line of governance through to the board, of course, and through to some of the subcommittees. But you've got to have a bit of elbow room to manoeuvre, and I think I've had that from my board. My exec team have had that from the board.
And then if you take it more widely, you think about your accountability as a trust then to the other bodies. How have you seen that line of accountability working? Has this approach altered your wider accountabilities?
In terms of regulators
Yes,
or system?
just in general.
God, well, I'll be really honest, but, we are grappling with, we've just called a summit, so we've called our regulators and NHSE and everybody round the table to try and work through some misalignment, shall I put it like that way. And we've held a number of these summits over the last 18 months. We find that quite difficult. It's challenging. They find it difficult. But, we've kept going with that.
Yeah. Heather, from your perspective, which, is different.
So at the other end of the spectrum,
yeah.
really. So, I agreed with my board right from the beginning that we would do the right thing by the population, and that might mean some significant changes in some of our services, and so I've kept them really cited on all of the developments as we've gone on. And interestingly, when we took our paper through our board just recently, the conversation at the board was how needing to have kind of more thought about how they can be fleet of foot to respond to the changes rather than allowing our governance to get in the way of the changes we want to make. So really thoughtful conversation with the board. And then on a very practical basis, for my mental health contract, I have a lead commissioner who has been, and that's been really important in terms of us being able to do a major inpatient reconfiguration across the county, reducing from sort of 15 not fit for purpose inpatient facilities, so a kind of master plan to go down to 4, and we've opened 2 brand new units. So there's something really important for me about the integrity of that cross-Lancashire work across 8 CCGs not being then undermined by trying to respond very directly to what's happening in Lancashire North, and having to have some different kinds of conversations between the commissioners to kind of free up particularly our community teams to work potentially in different ways within that overarching contract. So, and so far that's been fine, but part of some of my risk is whether being involved in different vanguards and different sub-health economies undermines what has been very purposeful in terms of having a Lancashire-wide approach to the very specialist end of my services.
Thank you. Thank you. Hugh, do you want to come back on any of that? Or?
I take from that it's very much work in progress.
Yes.
And that's what I would expect. But I suppose my conclusion on that is that the model that you're aiming for is not yet in vision, I think would be the best way of putting at it. But at the same time, you're describing that everyone is working together and not getting in the way of ensuring that the Vanguard itself works.
Yeah, it's probably not in vision is probably not correct. So we've got a very detailed 2 to 3 year implementation plan. If you walk about the patch, you can touch and feel new ways of working today. We've probably done it kind of, I was going to use a rude word then, but the wrong way around. In that we've been getting on with what is just banned or obvious and implementable. And I guess we've sought forgiveness rather than permission a lot.
I think the other thing to say is that what we've done is we've set ourselves, in effect, a 12-month timescale in which to come to a conclusion about what is the nature of the future organisational form. So we're going to work in this closer shadowed way over the next 12 months, but with a clear commitment that we'll use that 12 months to kind of really test what changes, structural changes have to happen to enable us to progress at the pace that we want, rather than focus on what we think that might be now and potentially make some of the wrong choices. So, for instance, we've said, you know, people talk about all of the barriers to integration. Well, let's test those and see actually with the right will and commitment, do you actually have to change, how much organisational form do you have to change to make that happen? And I suspect some of it will be surprising. In my experience, things as simple as being really clear about which policy people are working to when they come from 4 different organisations, but they're working together as a team, or get in the way of them being able to work well together. But it's not big, clever, you know, organisational form stuff, that's something much more operational.
Now, I mean, I take from that the conflicts of interest that you knew were there have been put to one side for the benefit of the patient.
Absolutely.
But I suppose my cautionary word to you would be those conflicts of interest still exist.
Absolutely. Yeah, and we're very aware of that.
Gentleman at the back, sorry. And then we'll come down to the front and then to you.
Yeah, hello, Dominic Conlon, Chelsea and Westminster. 2 questions, if I may. You touched on a key issue there about a number of schemes that you're involved in. And I wonder actually if you could say a little bit about, you used the great risk word, a little bit about some of the conflicts, not of interest in terms of governance, but around running parallel systems, either because there are 2 different new systems or because you've got a bit of the old system in play as well, and what balance you've got between the resilience of the old and the development of the new. That's 1. And then 2, if I may, like the rest of the room, I was probably equally inspired and terrified by Professor Williams's address about, and what I think he's really saying is a real understanding of your population and how we can establish, improve health. And as people have been thinking about that perhaps a bit longer than the rest of us, I wonder whether I'm not going to ask you what you've got in play because it's a bit unfair an hour after you've finished speaking, but what's that stimulated in your minds in terms of what that might take us to in terms of a better understanding of our population?
Okay, so Heather, do you want to answer the first and then I'll come to you in a second?
I guess at the moment it just feels like within our own organisation, within Lancashire Care, we just have to work, it feels like sometimes 3 times as hard to sustain everything. So there's real practicalities about how we physically service 5 different transformation boards between our executives, how we balance being flexible to what people say they want kind of locally, and how we get consistency across services. I think in our minds, sometimes the perception is bigger than the reality. So lots of the different health economies saying, we need something very bespoke for us. And actually, when you boil it down, it isn't that different. And so we're focusing on kind of quality, the sort of quality standards and our professional advice, particularly in relation to mental health services. I think it's an interesting point that we've discussed actually within the Vanguard around the notion. There's a bit of a risk, I think, that people think that if things are done in the community, that they're inherently can kind of be the governance and quality of those are easily managed. And actually, I think it's quite the reverse. And in mental health, the fact that we don't do stuff in a hospital doesn't mean it's not incredibly complex and specialised and very risky. So there's something about the governance of the models and ensuring that there retains adequate supervision and oversight of standards within a more integrated approach. And so we've been thinking a lot about how we might do that and have kind of referred to the kind of mothership and the relationship to the mothership, even if you like, staff are gifted into some kind of new organisation. So I think we just have to, it just feels like we work quite twice as hard managing those risks, actually. But I think it's the transition that's the problem. When you get to the final state, I can see an easy solution, but it's very messy at the moment. And there's a lot of brokering of conversations between the different commissioners and the different health economies about what is it really that you think is so different that you really want.
I'm just struck by one of what Chris said in the keynote speech as an acute trust chief exec in a trust that was very broken, is still in special measures. Fingers crossed we get our CQC re-inspection report in a couple of weeks' time. But, you know, thank you. But, you know, you've got one foot in the kind of holding on to stability. You know, you're straddling transition with a foot in transformation. And that's a juggling act, I guess all of us are kind of facing. And trying to communicate that to staff within the acute sector about, you know, improving day-to-day practice, etc., whilst also trying to describe, you know, this new accountable care system that we're creating. It is an absolute juggling act, and you're quite right. And I got my wings clipped this week by colleagues for, you know, a word that I got wrong in an advert that's out at the moment for our Director of Strategy. And you've just got to seek for forgiveness and just be quite pragmatic about it. And, you know, it's tough.
Yeah, but I like to think that we've created the environment where staff on the ground are just doing some really sensible stuff, almost below the radar. So as a classic example, in Lancaster, I provide the specialist mental health care home liaison team. Blackpool Acute Trust provides a physical health nursing home liaison team, and Jackie has a dementia in hospital team. And these teams just got together. They actually physically moved the Blackpool team into the building in Lancaster and said, if we just all work together, wouldn't this make a whole lot more sense? And then I found out about it after they'd done it, and it was just brilliant. And they're now working together really well, in-reach, outreach, supporting the across from care home into community and into hospital.
Yeah. Just two further points, if I may. We have invested quite heavily in OD. So we spent a lot of time working through what we need to do at all levels of these, you know, integration in order to make it as easy as possible. The other thing, just going back to your point about population and, equity, equality, etc. I think, you know, the real prize for us will be we're very privileged to have some very compatible joined up informatics and IT. And we've spent quite a slug of the 10 million Vanguard we recently got allocated on information systems, and we're really using that to accelerate what we can do in terms of understanding the needs of our population. So we're not at first base with that yet, but I think we will be quite quickly, just with joined up IT and information.
That's great. Okay, so gentleman down the front here who wanted to ask a question. The microphone is just coming.
Is it right in the front there?
Yeah.
Sorry,
Asha. And then I'll work my way back up the room. Yes, more hands. Great.
Thank you. Richard Patterson, Royal Brompton and Harefield. I don't really have a clear picture of what you're trying to do. What is this going to look like at the end? And I suppose, you know, you wouldn't start from here if you were trying to get wherever it is. But I don't quite see what the plan is. Can you try and define the plan in a couple of sentences? That would be helpful.
I can, and look on our website and you'll see it. And if you go on the Better Care Together website, you'll also see it, because that's the terminology we use. It is all about integration across the different sectors, including the ambulance trust and social care. So it's all about putting teams together. Heather talked about 12 localities. There, if you come up one step from that, they're in 3 locations. So North Lancashire, Kendal and Barrow-in-Furness. And it is all about providing care around the patients around in those localities. Interestingly, the GP federations are also organising themselves in that way. So at the centre of it is absolutely primary care. So it's around integration. We have been working, as you might expect, on some planned care pathway redesign. We've got 8 pathways that look completely different. Children's services look fundamentally different across the bay. They're all bay-wide provision. and and the same is true for emergency care pathways, and also important to this is a kind of advice and guidance service at either end in those 3 localities. So, you know, I've kind of gone full circle in my career in terms of GPs talking to hospital consultants. They actually have live conversations every day, all day, and sometimes during the night about the patients. So I hope that gives you a bit better feel. I probably missed lots out of there.
And our expectation is that that ultimately will be delivered by an accountable care organisation that will both commission and provide that service and take responsibility for the totality of the health care, well, the health of the population, which would also involve, obviously, the social care and wider determinants.
Okay. I'm going to move the question on to the gentleman in the middle, and I'll come to you, Jeffrey, and then you, Karen.
Thank you. Alan Arnott from Peterborough and Sanford Foundation Trust. So I'm sort of towards the same end of the spectrum as the last questioner there. I'm very I can hear the process. I can hear that you're in the process, and I can hear that something will get delivered down the track, and it will be a legacy for future generations, because it does sound like it might take quite a long time to get there. And I can hear the integration and the thoughts about a single budget maybe, and an accountable care organisation maybe is kind of sliding towards that. But I'm very interested to hear if you've got a clear picture on the outcome, what it looks like. I think I heard you saying that you did have a clear picture. It'd be good to know what that is. But also, have you defined the prize? Have you defined what sort of transformation in patient care or patient experience is going to happen, and that is which you're driving for? And have you defined the financial prize? You know, how many tens of millions of pounds are going to drag out of the overall cost structure as a result of doing all of this? Because that's when it starts having purpose, isn't it?
So, shall I begin? Yeah. We have, to a greater or lesser extent, defined all of those things. So where we started was the problem of the bay, and I talked about the quality failures, but you know, where there are quality failures, finance follows pretty quickly. So the prize, and I think this is like peeling the layers of an onion. So at the moment we've got savings costs of 30 million in 5 years that we're going to take out. That is just today's workings out. And actually, I suspect as we get into looking at next year and we do get greater integration, that number will get bigger. I could see it coming as high as 70 million across a budget of what's probably, I don't know, $750 million. So yes, we've got some hard-edged metrics. Yes, we've got some real deliverables in terms of both quality of care and capacity. You know, you'd expect the usual stuff around reduction in hospital beds, where I'm hoping to save around 70 outpatient clinics a week from next year. Actually, some of those are already happening this year. Reduction in length of stay is already happening. You know, flow through the hospital. I'm speaking from a acute sector provider. We tested it a couple of weeks ago. 2 wards worth of patients we were able to accelerate just working in the Bay way, as we call it. So yes, there are some real hard-edged tangibles, and more to come, I think.
Okay. I'm going to move us on to Jeffrey at the back.
Yes, I'm sorry, the previous speaker pinched my question.
Okay.
It was based on the finance of the individual organisations and whether you've done any financial modelling to get an idea of whether all this is fantastic for the patient and is it actually going to save money. But I think you answered that with a figure of 70 million, and at that point I passed the microphone on.
Brilliant. If you could give it to Karen there.
Oh, don't give it to Karen.
I'm taking chair's prerogative here. Give it to Karen.
Hi, Karen Partington, Chief Exec, Lancs Teaching Hospital. There's some fantastic work that's going on. But in his keynote speech this morning, Chris Hopson said that Vanguards and new models of working will probably take about 5 to 10 years to realise any benefits. And in Lancashire, we have over £800 million gap between now and 2020. I just wondered, how are we going, or how are you going to keep the Vanguard process moving for the future and deliver today's efficiencies today? Because I don't think there's going to be much mercy for any of us not doing so.
Shall I have a go?
Yeah.
Well, I suppose, notwithstanding the fact that we've got some targets around money and so on, personally, I don't believe that the Vanguards and all of the work that we're planning, even across Lancashire, is going to be able to close that gap. It doesn't mean to say it's still not the right things to do. And I think one of the big leadership challenges is to continue to do the right things, to do it to the very best of our capability, and continue to push the argument about, and you know, as Chris said this morning, have that honesty about there isn't another plan, we all know that, but I don't think this plan is enough. I think increasingly it's about how we collectively have those conversations, and we've had some very honest conversations with Monitor and others about the pace at which all of this can happen. And I suppose my sense, and Jackie might have a different view, is Monitor could have taken a very different approach with the Bay, and has actually allowed us to continue with this plan and believed us in that we think it's the right plan. You might say it's because there isn't another one, but at least they've held off rather than foreclose and bring people in and say, you know, that's it, stop, because I just don't think that's helpful. So I think the important thing, though, is that in the going, that none of us do anything kind of in a very selfish way that solves our problem but causes a problem for the rest of the system. And again, that comes from the quality of the conversations and the relationships, whether it's within the Bay or across Lancashire. But it's not going to solve it all, absolutely.
I think the only thing I'd add to that is it absolutely depends. I mean, it's about us being greater than the sum of our parts. And it absolutely depends on me delivering, you know, I've got a 30 million cost improvement programme. I've got an underlying deficit to that. You know, that's before we start to talk about the control total of the Vanguard. So it relies on each of us, you know, and it goes back to that stability, transition, transformation quadrant. You know, we've got to straddle it and we've got to very well deliver and keep things stable locally whilst we're trying to, you know, redesign the future. And it's a tough balancing act, and we've got to hold each other to account for that. You know, if Heather's position starts deteriorating, then it brings the whole control total. It starts to give us all a wobble. So, you know, that's the deal, really.
Yeah. It moves you onto a more symbiotic relationship, doesn't
Absolutely.
it, in a sense? Okay, Chris. And once we've had Chris's question, I'm going to be quite directive now. There are two areas that we haven't really covered yet. One is the relationship with the central bodies, and the other is about clinical engagement. So I will either ask those questions, but if people have questions from the floor, get your brains thinking in that direction. Chris,
yes,
unless yours is one of those.
Thank you. Chris Muller from Leeds and New York Partnership. Fascinating, isn't it? I was just wondering, however, about the local authority position. So does your financial model encompass where the local authorities imagine themselves being? Because as we all know, it's getting kind of more and more desperate out there. So, for example, in Leeds, the latest number that's kind of floating around is around 800 million over 5 years, if things don't change in some way. But two positives, if I may. Great focusing on the local population because it's about people, and I love the idea of people, clinical teams, just getting on with it and telling you what they've done later. I think that's absolutely fantastic.
So Chris, to start, we've got a sliding scale of engagement on this, what we're calling the MOU, the Memorandum of Understanding. So initially, it will be fairly obvious that the 4 FTs will play into that. Initially, the GP federations probably won't. There may be some individual practices that do sign up. The local authorities, Lancashire probably won't. Cumbria are debating it. But they do understand the risk, I think, and we've had explicit conversations of the risk of putting that social care provision in. And the risk is because, you know, services are just being pared back so finely that what we end up doing is, by necessity, just putting health cash into bailout social care. So it's not a done deal yet, and we're still debating it.
Yeah. But certainly at a Lancashire level, we've just done a piece of work which we call the alignment of the plans, which has explicitly looked at all of the 3 local authorities and all of the providers and all of the commissioners, and that's where the 800 million comes from in terms of the gap.
I'm just thinking of something astrological there, where the planets align.
Yes, well, it felt a bit like that, actually.
Okay. Does anyone have a clinically focused question, or shall I ask that? No, I'm going to ask it, no hand shot up. So really, I'm keen to understand how you've sought and got clinical buy-in for this new model, because we know that there's one thing focusing on structures, it's another thing about bringing together boards and other parts of organisations. But what about the clinical buy-in for this vision? And particularly because it's not just about one sector, it's about bringing together mental health, physical health, different sectors out in the community in your bricks and mortar. So perhaps, I don't know who wants to start. Start from your perspective.
What we've done, and again, it's probably important to recognise that this work started before the idea of a Vanguard came along. So actually, we started off bringing clinicians together to consider what the futures might be and what the clinical models might be. And those are iterating and enhancing as we bring different thinking in. But I think that's where we started. And I know in particular in Jackie's organisation, a huge amount of clinical time freed up with bringing, crowds of people together to have the conversations and work it out between them. And as we're working through the different places, so, my team in Garstang, we've said, well, you guys get together with the physical health teams and actually with the police and with other services and start to understand what is it that this population needs and what might your different contributions might be and what might be different contributions. And certainly the feedback that I'd picked up, and I don't anybody ask me what was the difference it made, but the conversation was going kind of one way, and then when the police came into that conversation, it completely changed the whole paradigm of the conversation around that population. So I think clinicians are hugely important, and there are other wider public sector voices that need to be brought into the conversation.
I think it's been quite. We have done it. I've had a lot of my clinicians engaged, but nowhere near the amount of GPs that are really ignited and passionate about this. I found it a harder job as an acute chief exec, and I have managed mental health and community services, but to get inpatient consultants really understanding the world inside out, if you like, and really seeing it through a different lens. But God, the GPs get it, and I think the challenge for us as kind of leaders is one, being true to that, and as we start to devolve accountability into the 3 localities, I can see the boards of those localities with their delegated budgets and etc. and their shared objectives. They'll be led by clinicians. So the challenge for us is staying absolutely true to that model, because they will quickly get disengaged if we don't.
Okay. Any further questions from the floor before Okay, I'm going to move on to the national bodies, and I think this is probably, we've touched on the role of the different central bodies, so Monitor and others, but I think it would be really good, and I'm sure that this is probably something for others in Vanguard or thinking about new ways of delivering care. What is the nature of the support you get from Monitor, TDA, NHS England, other structures to help you deliver this? And where do the pinch points come? Where are the crunches, as it were, with the central bodies? So I don't know who wants to take the step forward and talk about that first.
Well, I'll start.
I'll look at you.
So, and again, it's easier for me because I've not been in a position where I was feeling the full weight of the help from the centre up till now. I think I had really interesting conversations with CQC about where we're going and how they would need to change their approach, and that having not even just a single organisation perspective, but I mean, I was recently, 6 months ago, I was inspected and had 3 different teams who were looking at, my adult social care services, my mental health services and my physical health services, all totally separately, and saying, where we're trying to provide integrated services, how would you flex that methodology, because you can't accommodate that. And I think, and they're obviously in the consultation period and thinking at the moment, but absolutely needing to move to a place-based. But to be fair, the pushback was, if you can describe clearly your governance model as to whatever this future state is, then that's what we can regulate. But kind of don't criticise us for not being able to regulate you in that way when you can't absolutely describe how it works. Now, I think it's an interesting conversation, and we can kind of dance around our handbags around about that for a while, but I think it absolutely will have to shift, and quite fundamentally, not just in terms of the different organisations, but the nature of the services that we'll be providing, and that will be really important.
Interesting notion of you dancing around your handbags with the regulators, but Jackie, from your perspective, what about broader monitor?
Yeah, so I guess I have felt the full weight of every regulator, and it has been challenging. So the business case, because there is a business case, there is a delivery plan. We've kind of touched on these things for what we call in Better Care Together. As we start to move into delivery in a shadow ACS, we'll call it probably something different, probably Better Care Partners. But, in there, we're asking for capital provision for GP buildings, for hospital redesign. We've obviously, something that I don't talk about because it is a bit controversial, but we're the only trust to get a tariff modification, and actually negotiating how the cash comes through the system. Monitor, tick the box and tell you you've won it, you've won the prize, but unlocking that from the Treasury through kind of DH or NHS England is another thing. So the way that we've tried to kind of align it is just invite players around the table, and when we've done that, we've managed to work our way through it. But trying to do it in the absence of that has been incredibly difficult, and I would say that's without the TDA being kind of involved. I think Monitor have probably been one of the more straightforward regulators to deal with in my experience.
And just an additional question. So what kind of practical support have you had, say, from the new care models team or anything? Have you had that hands-on support?
Yeah, I think actually they've been great, and have been giving really clear commitments to almost say, you push us as hard as you want in terms of what are the things we need to unlock, and expressing a very strong commitment to doing that, and actually pushing us a bit in terms of, can you be more radical? Is there more that you want? Don't be constrained in any way by the things you think are the rules. We're here to pull down those walls and get those rules changed for you. And I mean, this recently came up, and we've been looking at what we've been doing. I guess it's still early days, and I think they'd be the first to admit that it's early days for them too. So there isn't kind of piles of things that they can say, we've concretely done this, but I think they're getting geared up to be able to.
I mean, they were really ready to, allocate cash support. Like you say, they've been given really, really clear feedback. One of the other things that we've not talked about, we have spent quite a lot of time as a system working with Alzira. We've been over to Spain, they've been over to us, and we haven't really talked about that, but we've got a strategic partnership with that healthcare system. Massively important in terms of influencing our thinking and our priorities, particularly around integration informatics. They've really done a great job across their system.
Okay, I throw it out back to you, to anyone who's involved in a Vanguard or a new model of care. Want to comment on how they're finding the relationship with regulators, because it would be interesting to see how this is or isn't replicated, because one of the things we do ask from our regulators is a consistency of approach. So it would be kind of good if anyone out there is prepared to comment on that. John, over, sorry, Asha's diametrically the other side of, yeah, go around the outside. So it's a big room with only one microphone.
Hi, John Lord, Chief Executive at Northumberland Town and Wear Mental Health and Disabilities Trust. I think to answer your question, first of all, a bit of context. If you include our 2 ACOs and our PACs and our multi-specialty provider and our care home and our urgent emergency care vanguard, the first comment would be that it'd be nice if there was some rationalisation of all of these things. So I think from an NHS England point of view, that would be our biggest question, is how do we make sure that this doesn't just proceed with lots of cheese plants developing across the NHS. So I think we've got an awful lot of them now, and we've got a cheese plant tree. So I think that's not a regulator per se, but there's a real issue for me about carrying on the analogy. The 1,000 flowers blooming is creating huge pressure on organisational capacities. I've attended 2 ACO programme boards in the last week, and we're really stretched. So I think that's not so much a regulatory point. I think I'd agree with Jackie. I think Monitor are being reasonably sensible. I do think there's an issue where the vanguards are being led by a single organisation to make sure that when we talk about a significant transaction, it's looked at from both the leading organisation and the organisations that may have some of their services directly impacted on at the same time, because that's not particularly happening at the moment. And I think the CQC thing, I think it's too early, but we're all being CQC'd very separately as organisations, because obviously that's the model that is currently in place. But that's already an outmoded model for us in one of our footprints in Sunderland, where we've got huge amounts of resource in the Better Care Fund joined up and effectively a pool budget for the vast majority of things. So I think a bit of a long comment, but so I suppose I'd just like to understand, probably from Karen in particular, how's that working given that you've got a number of vanguards on your pitch? Perhaps maybe not quite as many vans and quite as many guards as we've got.
Sorry, John, what was the question?
In terms of...
I said, Heather, sorry, apologies, Heather. No, it was just, I think you mentioned in your bit about a number of different vanguards in your patch. So it was really just to understand from your point of view, are you having similar difficulties with capacity, but also how the various different regulators are looking at you still organisationally rather than sort of as a system?
Yes. So, yes, absolutely, in terms of capacity. And they're actually kind of forming quite differently. At the moment, like you, I think it's a bit early in terms of the regulation, but I can anticipate within the next 12 months or so that it'll start to be a problem if they aren't flexible and are responsive to those changes. So, you know, we're surviving at the moment, but and I think it's my comment to colleagues earlier about just having to work extra hard. You know, I can't physically be at all of these, so it's about how we spread it out between the executive team, how we keep connected with all of these things and then make sense of it, particularly for our clinical services, because, you know, previously we've been trying to be, you know, very consistent in terms of the offer to the population and now trying to be very different in terms of some of that.
Thank you. So we're nearly at the end of this session, so I just wondered if you could both give just a few words on perhaps what advice you would give to people, sum up your experience so far and what advice you would give to others embarking on such an endeavour.
Oh, blimey, keep at it, I think. I think the piece about clinical engagement, I don't think we'd have got anywhere near as close to something that feels like it's working, actually living and breathing without clinical engagement. I think just make sure you focus on the people. It's all about the people at every level. And, you know, the relationships, there's no room for any egos, there's no room for throwing toys out. You've got to do the right thing by the patients and keep that focus in mind. And you've got to be in it for the long haul. So we're having some interesting discussions as leaders about how you keep, particularly chief executives, in place, sat on the seats long enough to get to the end point.
Yeah, I would agree with all of those things. I do think fundamentally it comes down to relationships, actually, as you say, at every level, in terms of making it possible, because if you've got the will and the strength of relationships, you can get through the difficulties. I think the other thing is to keep your eye open all the time for the opportunities to progress things that sometimes come a bit left field. So if you take the Milham work, which is fantastic, but came from a kind of crisis where villagers were in the streets campaigning for because there was concern about their local practice would no longer be there, and is now a fantastic example of community engagement, asset building, and different partnerships to come together. We could never have predicted that if we'd had the most perfect Gantt chart in the world, but it's about spotting those things and turning them to your advantage rather than seeing them as a problem. And I guess if you have that kind of attitude, it'll stand you in good stead for the many pitfalls that we'll face over the next few years.
Thank you. And I think what I've taken from this discussion today is that you have really brought to life, for me, and I hope for the audience as well, this sense of what it's actually like to live in a world of Venn diagrams, where you're looking at your overlap with everybody around you, and you're sitting at the centre sometimes, and sometimes you might be kind of right up in the distant reaches and, you know, a lone player, and then other times so many people converging on your patch. I think that what's also come through for me is that relationships are fundamental. They are the glue to making all of this happen. And I heard the word brokering several times, and I think that fundamentally this is about brokering relationships, brokering agreements, brokering how you put the toys back in the pram once they've been thrown out, if that happens, and in order to push this forward. I would really like to thank both Jackie and Heather for being so honest with us today about their experiences and talking about what it's been like for them in their journey, which started way before the Vanguards came into place. And I think that's also something interesting to note, that lots of this stuff has been happening already, and spotted the opportunity of the Vanguard coming along. So perhaps if we could thank our colleagues in the usual way.